So let me begin with thanking the organizers for giving me this opportunity to present before you a very important topic titled Smokeless Tobacco Use Among Women, a Neglected Issue. And my apologies for not being able to come in person. So I bring greetings from the WHO FCTC Knowledge Hub on Smokeless Tobacco, the National Tobacco Testing Laboratory, and the ICMR, National Institute of Cancer Prevention and Research, Noida. So here are the few slides that I will share, and I'll be able to convince you at the end of the session as to why this issue is important and how we underestimate the problem and why we need to pay attention to the use of tobacco products by women. Talking about smokeless tobacco products, smokeless tobacco products are defined as products which contain tobacco, but instead of being smoked or burnt at the time of use, they are consumed either orally or nasally. And they are placed in the mouth or the cheek, lip, or under the tongue, and they are sucked and chewed. They are also used for gargling and also as dentifrice. And a wide variety of these products are available across the globe, but I'm sharing some of the common products which are found in the Indian market. And these products contain various other additives such as areca nut, chemicals, heavy metals, the flavors, spices, glycerine, oils, and camphor, salts, and hydrating agents. And some of these products are also mixed with slaked lime, which changes the pH of these products. These products are produced in the homes or in small cottage industries, and often women and children are employed in the workforce. These products do not, most often do not contain any labels regarding the ingredients. So coming to the harms of smokeless tobacco products, like smoked tobacco, the active ingredients in these products is also nicotine, and so it affects almost all parts of the body. And these smokeless tobacco products contain more than 3,000 constituents and in various proportions. Now, the mechanism of action of nicotine, most of you would know that the nicotine binds to the nicotine acetylcholine receptors, which are located on the muscles and the brain. And these are stimulated to release neurotransmitters, which affect many bodily functions, affect mood and behavior. And the dopamine reward system is also related to tobacco use, and this gives the users a sense of mood elevation and enjoyment. Now, nicotine, we are talking about how it affects women. So we are going to see how the nicotine affects the reproductive system. Nicotine gets absorbed in two forms, protonated and unprotonated form. And the slaked lime, as I had mentioned earlier, which is added to these products, facilitates the crossing of nicotine across the cell membranes, and further nitrosation of nicotine occurs to give rise to TNSAs, which are group 1 carcinogens. Also to note is that higher levels of nicotine can enter the systemic circulation when we consume smokeless tobacco rather than smoking. So this study was done by Benowitz and earlier in 1997 and later in 2014, and these are the references, that they found that the nicotine in the systemic circulation was higher as compared to when a cigarette was smoked. And these are the values which they found at after 30 minutes of absorption. And chronic tobacco use has been shown to disrupt reproductive functions in the women, like the disturbed hormone levels. They disturb the impairment, they cause impairment of fertility, they cause toxicity to the ovum, and they're also responsible for pregnancy complications, miscarriages, and stillbirths. Coming to how nicotine affects pregnancy, as you can see this in various studies, they have found that nicotine easily crosses the placental barriers, and the level in fetal circulation are 15% higher, and in amniotic fluid, they're 88% higher than in the maternal plasma. And no wonder nicotine causes fetal growth restriction, low birth weight, preterm delivery, and the restricted placental oxygen supply to the uterine blood vessels happens due to the effect of nicotine. Also, nicotine metabolism in pregnancy is different, and these are activated due to enzymatic pathways, and there's increased metabolism of nicotine, because of which the craving continues to be there during pregnancy, and studies have reported that it makes quitting difficult during pregnancy. So on the fetus also, it almost affects almost all parts of the new fetus, different organs which are growing. And there are neurobiological effects, there are cardiovascular effects, there are pulmonary effects, and even the facial movement patterns of the growing fetus is affected, as you can see in this picture. So it affects almost, adversely affects almost all parts of the growing fetus. Now, in lactation, it has been found that in breastfeeding mothers, the nicotine in the systemic circulation gets transferred into the breast milk, and it gets accumulated in the breast milk. It is 3 times higher than that in the blood, and higher concentration of nicotine is found in breast milk of smokeless tobacco users as compared to those of the smokers. The nicotine also adversely affects the milk composition, the milk volume, and it shortens the period of lactation. So there are so many harmful effects of using tobacco during pregnancy and lactation. And through the breast milk, they pass on to the infant, and the infants of mothers who use tobacco, either smoking or smokeless tobacco, their urine contains measurable amounts of nicotine and cotinine. So you've seen all these different effects of smokeless tobacco, as well as smoking and nicotine, the active ingredient, on the women, the pregnancy, and the lactation. So that is why here we are discussing it. Especially because this is the data of Global Adult Tobacco Survey 2016 to 17, and this shows that nearly 12.8% of women between over 15 years of age, they were found to be using smokeless tobacco products. And as you can see here, the blue portions show the smokeless tobacco, the red portion shows the smoking. And the lower 2 pie charts, they show that in women, mostly smokeless tobacco products are commonly used, as compared to men, who only 61% of men use smokeless tobacco, 39% smoke, whereas in women, 6% smoke and 94% use smokeless tobacco products. This data, again, it's in the graphic form, which shows the trends of smokeless tobacco use among women in India. And noteworthy is that during this survey, it was found that there was more than 10% prevalence of smokeless tobacco use amongst Indian women in nearly 16 states. While there has been an overall decline in smokeless tobacco use from 18.6% to 12.8% between 2009-10 and this current survey, there was a relative increase in 9 states, which is alarming. And also important is that women under 15 years of age, it has been found that only 11% men use smokeless tobacco, whereas for women it was 17%. So the women start using smokeless tobacco early on in their lives. And these are the various states where smokeless tobacco use is more common. So we have to pay attention to these states, and especially those in which the use is showing a rising trend. Now, we did this very important study to map the burden of tobacco use and alcohol in at the district level. This was the first survey of its kind, which mapped the use at the district level. And as you can see here, while in only 24 districts, 1 in every 10 women smoke tobacco, in 133 districts, 1 in every 10 women chew tobacco. So this map shows the importance of curbing smokeless tobacco use among Indian women. From the same study, it was found that women in the central, western, eastern, and northeastern region, they mostly consume gutka and keni. We have shown that earlier also. These are the most popular smokeless tobacco products among women. And in over 130 districts, the gutka use among women is between 10 to 20%. So these are the figures from the district level mapping of the use. We also did recently publish this study from, the data was from the DHS and the multiple indicator cluster surveys of 78 low and middle income countries, which was collected between January 2010 and December 2019. And they showed that the pooled prevalence of smokeless tobacco use overall was 2.5%, but it was highest in the SEA region, in which India is also there. So there it was nearly 5%, 4.92%. And amongst these countries, the illiterate and the poor women in the low and middle income countries bore the enormous burden of tobacco use. So again, we know where we need to focus our attention. Moving further, we also studied the GATS data 2016 to 17, where it was found that while in India, only about 5.8% of adults have been able to successfully quit smokeless tobacco use. This was their attempts and intention, and actual cessation was compared between men and women. And it was found that for each of these figures, that is the current smokeless tobacco users who thought about quitting because of a warning label, or those who were planning to quit or thinking of quitting, or those who attempted to quit smokeless tobacco products, or those who were advised by the healthcare providers to quit smokeless tobacco products. For each of these, the women in the group were showing a lower prevalence. So we did think that equity is very important, and a gender-sensitive approach is equally important to be able to help women to increase their quitting attempts and also be successful quitters. And for this, their knowledge, their access to cessation, their willingness to enroll in cessation programs, the associated stigma, the associated cessation methods should be gender sensitive. Coming to the gender sensitive part, we recently have published another study which has been studied using the data available in NFHS from the domestic violence module, and it examined the odds of smokeless tobacco use reported by the women respondents based on their privacy status. So it was found that when the women were interviewed either in the presence of their spouse, husband, or any other family member, they tended to underreport the smokeless tobacco use. And this was especially common in Central and Western India. So we need to improve our data collecting methods, especially in these large-scale surveys, because they can underestimate by nearly 20% the smokeless tobacco use or just tobacco use. So it is important for us to understand, what are the reasons behind the women using smokeless tobacco, and also why are women smokeless tobacco users neglected, not only in the numbers, but otherwise as well. So various studies have been done to address this concern, and what they have found is that the context of female tobacco use is complex. It is dictated by socio-cultural factors and economic independence, such as autonomy, identity, and social status. In some households, there's a affluence status attached to smokeless tobacco use. And in India and the Southeast Asia region, smoking among women is accompanied by social disapproval and stigma. But smokeless tobacco use holds cultural sanction. So no wonder smokeless tobacco use is much higher than smoking rates in our country. Also, not only in our study, but other studies have also found that there's a discrepancy amongst the self-reported rates of tobacco use by women, and those have been validated by biochemical analysis. And the pregnant women and the lactating women were the ones who actually also underreported. Now, all these are because of their poor knowledge of harmful effects, their low levels of literacy, which prevents them from noticing the health warnings or seeking quitline services, and leads to neglect of women for receiving vital cessation services. We did participate in a multi-country study on smokeless tobacco cessation, where Pakistan and Bangladesh were also the other countries which participated. And in this randomized control trial, we found a very high quit rate amongst smokeless tobacco users over a period of 8 weeks. And we also had quite a few women smokeless tobacco users. And what we found was that women showed much more dedication and compliance to the advisories provided in the study. So in summary, we'd like to point out that the current estimates of smokeless tobacco use reporting are not sufficient to understand and gauge the burden of tobacco use among women. The ongoing programs related to maternal and child health need to be highlighted as regards the smokeless tobacco use, as this is a potential threat not only to the women, but also to the newborns. The health warnings and the pictorial warnings on tobacco product packaging should depict the products to be harmful for women and the newborns. There can be tailored tobacco cessation strategies among the pregnant and lactating women. There can be more effective implementation and enforcement of tobacco control measures under COTPA to protect the women. And it is essential to articulate the rights of women as human rights and engage in the development of gender-sensitive tobacco research. Thank you for your kind attention, and I hope you all enjoyed the talk, and I hope I am able to convince you at the end why we need to pay attention to the smokeless tobacco users who are women. Thank you very much, and these are acknowledgements. Our staff from the WHO FCTC Knowledge Hub on smokeless tobacco, and the entire team of NICPR scientists, the collaborators, and their patients. Thank you.